for today's vertical integration session, Asking for Help. My name is Sydney and I'm from the PHN Education team. Before we begin, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Darkinjung land, and I'd also like to pay respect to elders past, present, and emerging. Now today, I'm joined by Dr. Renee Pope. Dr. Pope is working part-time as a GP registrar at Your Family Doctors at Erina. She grew up locally, completed a Bachelor of Pharmacy at the University of Sydney, and worked as a clinical pharmacist at both Gosford and Royal North Shore Hospitals. After graduating from medicine from the University of Notre Dame in Sydney, she returned to the Central Coast. She now enjoys the wonderful work-life balance that the region offers. When not at work, she spends time chasing her toddler and her golden retrievers across the local beaches. Now, a few things to let you know about the session. It is being recorded and will be available for you to view in our vertical integration library in a few days' time. As attendees, please feel free to keep your camera on, off, microphones preferably muted to begin with. But if you have any questions, please feel free to chime in or pop them in the chat. And then I will link the QR code for the Slido at the end, and we'll also run through all of our Prezi winners. So we do a lucky door prize of $50 every session. So we were going to go through and share the last few months of who our winners were. So I will hand it over to Dr. Renee Pope.
Thanks, Sydney. Thanks for attending this morning, everyone. So I'll just get straight into it, I think, just because I'm a bit conscious of time. So I just preface the presentation, I guess, by saying that as a GP Term 1 registrar, I've learned a lot from this case. And so I hope that throughout the story, you can kind of chime in and offer some words of wisdom or some suggestions of potentially what you might have done throughout the case study. So let's begin. So this all happened, sorry, I'm just gonna, those pesky golden retrievers. So this all happened one Thursday morning. A 29-year-old female presented accompanied by her husband. So she was G1P0 and 36 weeks plus 2, and she was sent in for the review by her midwife with 48 hours of kind of severe banding bilateral upper abdominal thoracic type pain, and the midwife wanted her to attend because she was quite concerned that she might have something like pneumonia or a non kind of obstetric presentation. So on further history, so she described the thoracic pain as kind of a banding around the back, wrapping around her chest anteriorly, and it had been gradually worsening over the last 2 days. It was almost a pleuritic type pain, worse on deep breathing. Strangely, she said it kind of got worse when she moved around, and importantly, it was so severe that it was actually waking her from sleep, and she was kind of having Panadol regularly to maximum dosage, and became quite teary during the interaction. Said, "Look, I'm in quite a lot of pain. Can you help?" So further history again, sorry. So she kind of had no real other associated symptoms. She had no coryzal illness or URTI type symptoms. She had no changes to her vision, no headaches, no type of epigastric type pain or bowel change in bowel habit, no urinary symptoms, so to speak of, and she didn't have any kind of edema or any causes for concern, really. It's just kind of this pain in her kind of upper abdomen. Examination wise, her vitals to me when I first looked at them didn't seem too bad. So oxygenation was good, so saturating at 98 with a respiratory rate that looked quite comfortable. Heart rate was 68 and her blood pressure was 145 on 80. She appeared well groomed, becoming quite teary throughout the interaction, and she was kind of preferring to stand because of the pain. She was talking in full sentences and no other kind of increased work of breathing or use of accessory muscles. Auscultation, her chest was clear to the axilla and the bases bilaterally, heart sounds were dual, and she had no other real kind of symptoms apart from some tenderness over the upper abdomen. And she was reporting normal fetal movements. So I just thought I'd kind of throw it out there to see what everybody, I guess, based on that kind of presentation would be thinking at the moment. And then I'll kind of share with you all what I was kind of thinking. I'm not sure if you wanted to pop some things in the chat or... How are we going, Georgia? Anything there? Otherwise, I'll just move on.
We've got preeclampsia,
Mhm.
or preeclampsia or spleen, gallstones. Yeah, I was thinking maybe gallstones as well. Musculoskeletal.
Yeah.
That's a good one. Gastritis.
Yeah, good. So I think I probably had quite a basic approach to this. So I'll just run through my list of differentials that were running through my mind. So initially, because of the reproducibility of the pain, I was thinking, oh, maybe she's, got a lat dorsi type strain or something like that. It was very positional, tend to palpation. I wasn't really convinced with the concern for pneumonia. She had no kind of preceding coryzal symptoms and she looked really well. I did actually go and chat to my supervisor that day, and we kind of talked about maybe she had an embolism happening. And I think more from a point of view of not really being sure about what to do if we were to do a CT in pregnancy. I kind of maybe didn't touch on this a little bit further, but we just kind of talked about D-dimers being elevated in pregnancy and, what investigations will we do? I'm not going to go down that path further for this presentation though. Cardiac issues, gastric, as I kind of thought, as we've got here, some gastritis or some gallstones, and also just noting the hypertension. Something neurological, less likely, and then as Chris has said, and some other people have said, maybe some preeclampsia there. Infective, maybe some pyelonephritis, some vertebral angle tenderness and things like that. So I just wanted to touch on hypertension at this point. So her blood pressure was 145 on 80. And I'm not sure whether I kind of twigged at this point as to whether, that was a real hypertension. So I thought I'd just talk about that briefly now. So systolic hypertension, systolic blood pressure over 140 or a diastolic blood pressure over 90 is kind of considered hypertension in pregnancy. So in a normal pregnancy, we would expect a fall in blood pressure within the first trimester and in the second trimester, with a return to kind of that preconceptual levels by term. The guidelines kind of recommend hypertension being taken on at least kind of 2 occasions, at least 4 apart, before you give that diagnosis. And they also suggest that maybe detecting a rise in blood pressure from booking or preconception levels of greater than 30/15 might be useful for women who don't actually reach kind of targets above that 140 mark. Severe hypertension is kind of defined as greater than 170/110, and we're kind of instructed to commence treatment in pregnancy if the blood pressure is above 160/100, with urgent treatment being started at above 170/110. And that's for risks like cerebral perfusion pressures and cerebral hemorrhages and nasty things like that. Chronic hypertension, gestational hypertension, or kind of preeclampsia superimposed on chronic hypertension. So I thought I'd just run through these briefly. So we have the chronic hypertension could be essential hypertension or secondary, with essential hypertension being 140/90, and that exists before pregnancy or before that 20-week mark without a known cause. As we all know, secondary causes can include things like renal causes with diabetic nephropathy or reflux nephropathy, glomerulonephritis, vascular causes, coarctation of the aorta, and endocrine causes. So gestational hypertension is defined as new onset hypertension greater than 20 weeks with no maternal or fetal features of preeclampsia. So up to 25% of women will develop this, and it generally returns to normal within 12 weeks postpartum. If it exists after that kind of 3-month mark, that's when we're needing to investigate further and define that as chronic hypertension. So now preeclampsia superimposed on chronic hypertension is defined as chronic hypertension with the additional features of preeclampsia. And it's a pre-existing hypertension is considered a strong risk factor to developing preeclampsia. So guidelines recommend that we investigate hypertension in pregnancy. So we're looking for proteinuria and doing some preeclampsia bloods, which I'm going to talk about later. And I kind of suggest that you do this kind of weekly or bi-weekly, depending on the severity. So my next question to you all is, what would you do next? And George has just run away, so I'll just continue. So did a dipstick. So her bedside urinalysis came up negative for nitrates, negative for leukocytes, glucose was negative, and there was a slight increase in protein. So I put down a 1+ protein. So importantly, dipstick testing is not actually accurate to confirm or exclude significant proteinuria. Repeated dipstick testing does increase the specificity and sensitivity, but it's actually recommended that a spot urine PCR be done to confirm proteinuria if we're suspecting something like preeclampsia. So what I did next, and whether this is, up to experience or not, but she seemed well in herself despite the pains. We kind of discussed pain management with some lifestyle recommendations to continue Panadol. We talked about maybe introducing some opioids if the pain got severe or worse, and talked about potentially physiotherapy. She was well supported socially, and she was linked in really well with a midwife program. So I was thinking that she was pretty well supported here, and I was kind of happy to send her away with some urgent blood tests, sending off the urine for a formalised spot PCR, and doing some preeclamptic bloods, which were EUCs, LFTs, a full blood count, some inflammatory markers, and I threw in iron studies for inflammatory purposes. We talked about monitoring her blood pressure, and she didn't actually have a blood pressure machine at home. And so I said to her, look, maybe pop down to the pharmacy in about 4 hours and see if the blood pressure's gone down, because I wasn't sure whether it was kind of related to her pain at that point. And then I continued on with my day. So later that morning, I hadn't heard from the pathology company, so I gave them a call. So they told me that the liver biochemistry machine had been broken, and her biochemistry had been sent to Sydney, and they expected it overnight. But they had in fact had her full blood count and her coagulation studies come back. Sorry. Okay, so this was her full blood count. So relatively looking okay, except for the elephant in the room there, the platelets. So we're looking at a moderate thrombocytopenia with platelets to 59. So at this point, I was a little bit worried that I'd sent this patient home, but I ended up sorry, the coagulation studies were all normal. So I ended up giving her a call and just saying, look, blood tests have come back. I think we need to get you into hospital. And that's what we did. So wrote a little letter there to the doctor saying, I'm concerned for possible preeclampsia and HELLP syndrome. Her platelets have dropped from, 305 on pre-booking bloods to 59. We need to get her to hospital for urgent review. So just wanted to touch on preeclampsia now. So Chris, you're on the money there. I tried to not give it away, but it's probably a little bit obvious. So just delving into a little bit of pathophysiology. So we know that preeclampsia is a disease of the placenta, and we're not sure of the exact mechanism, but the current theories are that it's due to kind of poor placental perfusion due to abnormal placentation. Sorry, that's a mouthful. So usually in placentation, and I'm hoping you can kind of see my cursor here. So normally we see the trophoblast kind of invade or implant here in the myometrium. And they actually come in here and they break down the tunica media smooth muscle of the spinal arteries. And this causes the integrity of the muscle walls to break down, and the spiral arteries then dilate and they aren't able to constrict. So the placental and the pregnancy has a good blood flow here, good oxygenation, and there's a lot of resistance. So the suggestion is that in preeclampsia, this process doesn't occur correctly, or it occurs abnormally, and the placentation doesn't have that breakdown of that muscle wall, and so there is increased kind of constriction and increased resistance in the spinal artery walls, leading to kind of lower circulation. That kind of results in a increase in blood pressure, hypoxia, and oxidative stress, and poor perfusion, leading to almost a systemic inflammatory type response. So the classification of preeclampsia, I think, has been reviewed multiple times, and there's still a bit of disparity in what is deemed appropriate. So I think the British NICE guideline still has a requirement that you need proteinuria. Internationally, however, this is becoming less important in the classification. So it's defined as a multi-system disorder unique to human pregnancy, characterized by hypertension and involvement of one or more other organ systems in the mother or the fetus. So hypertension is common, but not always the first manifestation. And proteinuria is common, but it's becoming not mandatory in classifications. So it is defined as occurring post 20 weeks gestation and is accompanied by one of the following. So renal involvement with significant proteinuria on dipstick or confirmed in spot urine protein to creatinine ratio. Pardon me. Hematological involvement with thrombocytopenia or hemolysis. Liver involvement with a raised serum transaminases or severe kind of epigastric right upper quadrant pain. Neurological involvement with those headaches or hyperreflexia, convulsions being deemed eclampsia, and then other signs involving kind of pulmonary edema, fetal growth restriction on ultrasound, or peripheral edema. So a bit of a quiz here. So which of the following is classified as a high risk factor for developing preeclampsia during pregnancy? Feel free to shoot into the chat. So we've got family history. Got one for age, yeah. And these are from the British guidelines as well. Sorry, this classifying high and moderate risk factors, all of the above, yeah. So they say actually chronic hypertension is kind of one of the leading high risk factors for developing preeclampsia during pregnancy. So this table is taken from the RAND's COG guidelines of management of hypertensive disorders. So we have risk factors that it's thought to be likely to require a combination of an underlying susceptibility with these risk factors and then a potentially triggering event. And I think multiple studies have looked at trying to kind of predict the severity of preeclampsia, but at the time that this study was published, they haven't really come up with a risk stratification as yet. So in a prospective study, there was about 3,500 nulliparous women looked at, and around 55 developed preeclampsia. The risk was increased when more than one of these risk factors was present. The rate of preeclampsia when systolic blood pressure was greater than 120 at 15 weeks was around 14%, and that was further increased if she had obesity. It rose to 16%, and then with a family history added on, that rose to 20%. So almost a can't say that word, sorry. Almost adding up of risk factors to receiving preeclampsia. And interestingly, protective for preeclampsia, I just thought I'd mention high fruit intake was mentioned, along with smoking, which we won't condone, having a miscarriage with the same partner, I'm not sure of the kind of pathophysiology behind that one, and taking greater than 12 months to conceive. So clinical features of preeclampsia, as we kind of know, so headache, potentially more frontal headaches, visual disturbances, nausea, vomiting, that right upper quadrant or epigastric type pain, the neurological signs of hyperreflexia, clonus, epigastric or right upper quadrant tenderness, and severe peripheral edema. And sometimes the mild preeclampsia is frequently asymptomatic without physical signs. So linking that back to our case, I feel like I'm excused for not going straight off the bat for having that as a diagnosis straight up. Complications of preeclampsia. I'm not going to read those out, sorry, I'm just conscious of time, but we've got HELLP syndrome and eclampsia. And investigations, we've kind of touched on this as well. So just a urine dipstick, preeclampsia bloods there, and an ultrasound. So back to our case study. So our patient attended the birth unit, and where they repeated the pathology, and in the meantime her other bloods had kind of come back, and this is what we didn't see. Actually, this is all done retrospectively, but we're seeing a rise in her LFTs. Her lactate dehydrogenase so is 546, ferritin's 530, and CRP is 79. So she was promptly diagnosed with HELLP syndrome. So HELLP syndrome was first kind of coined by Dr. Louis Weinstein in 1982, and it stands for hemolysis elevated liver enzymes, low platelet syndrome. It's considered a variant or a complication of preeclampsia. However, I think more recent studies are suggesting that it may actually be an entity in itself and is to do with liver endothelial dysfunction that kind of results in this consumptive coagulopathy, where the women get microangiopathic hemolytic anemia. So determining the etiology is important. I think as in HELLP syndrome, it requires delivery. So if we're having these kind of hemolytic type syndromes, determining whether it's something like a TTP is important, because I think the TTPs can be managed without delivery, but HELLP syndrome is quite important as it does require that delivery as part of the management. So it occurs in 0.5 to 0.9% of pregnancies, and this is data I think pulled from America and the UK. 70% of cases occur in the third trimester, and 30% of cases can actually occur in that 48 hours post-delivery. There's a reasonable kind of high mortality rate, and it's very variable, I think, determined by country and access to services and time that it's picked up. So it varies between 0 to 24%, with perinatal death being up to 37%. Some risk factors for HELLP are suggested to be preeclampsia, having previously had eclampsia or preeclampsia, possibly a family history of both. Loose kind of evidence for autoimmune conditions like lupus and clotting disorders, and they don't actually recommend postpartum looking into clotting disorders and things like that. So just to look, sorry about this slide's a bit busy. This is me trying to kind of pull 3 different sources of pathology as I follow this case along. So looking at how our patient was going through her time in hospital. So we saw her peripheral blood smear kind of on the 30th of the 11th, came in with microcytes and mild polychromasia. She didn't have any schistocytes or fragmented cells, and she had that moderate thrombocytopenia So that was kind of day one of her admission. On the second of the first, we see schistocytes appear, and she's got all sorts of things on her smear, bite cells, helmet cells, and contracted cells. I'm not going to go into those. I'm by no means a hematologist. So laboratory test results that confirm hemolysis include reticulocytosis, as well as increased lactate dehydrogenase, increased unconjugated bilirubin, and decreased haptoglobin levels. And we can see if we follow kind of the haptoglobin, so she's got reduction of her haptoglobin here, resolving on the 6th, and her reticulocytes are slightly increased here on the 2nd. Her lactate dehydrogenase is kind of on the 30th, which is when we saw her in general practice, 533, and then on the 2nd, of December, that blood smear is wrong, sorry, that should say December, we've jumped to 1200, so it's quite an initial jump there. The direct antiglobin test further differentiates immune causes from non-immune causes, so hers was negative. And we've talked about the peripheral blood smear. So these are her liver function tests. So we see a kind of a global transaminitis here. This was post-op. Or post-delivery, I should say. And we see an extreme rise here. I'm not sure if this is a true, accurate kind of picture of the liver, or whether there was a bit of hemolysis on the sample. The pathology lab kept commenting that maybe there's a recollection suggested. And then that seems to kind of settle down as we go on. Her platelets here, so we see thrombocytopenia getting down to kind of 30 on the 2nd, and then resolving, and I'll talk about that in a moment, what actually happened in hospital for her. And I think this is the day of discharge for her. The platelets had come back up to 230. So sorry, I just wanted to put all the pathology in there, and so we kind of see how things kind of got worse and then they got a bit better for her. So to talk about management now, so as hypertension in pregnancy and preeclampsia and HELP. So which of the following antihypertensive medications is first line in the management of preeclampsia? So we've got methyldopa, labetalol. Yeah, another labetalol. Yeah, so it's labetalol. So in gestational hypertension, we talk about lifestyle modification first, but then when this kind of fails to control blood pressure, we move through to starting antihypertensive medication. So consider methyldopa or labetalol, and if it's severe, they commence hydralazine. So this is the RAMS called kind of guidelines here, and they're kind of taking into account kind of contraindications and other things. So I guess just to note the labetalol there, so it has that vasodilator effects, can have that rebound kind of headaches and bradycardia as well. So I'm just moving on, I'm just conscious of time here. So management of preeclampsia. So delivery is the definitive management. So if less than 32 weeks, they recommend a tertiary institute involvement for the NICU requirements. And we class kind of management of preeclampsia as kind of immediate management or expectant management. So immediate management is a delivery planned within 48 hours after the blood pressure has been stabilised. And we consider whether we give corticosteroids for fetal maturation, lung maturation, and magnesium sulfate for the neonatal neuroprotection there. Expectant management is a prolongation of pregnancy beyond 48 hours with close maternal and fetal monitoring. So there's two big studies that have been done in this. The HYPERTAT and HYPERTAT-2, and they compared the outcomes of induction or immediate delivery versus expectant monitoring in these women between 36 to 41 weeks and 34 to 37 weeks. And essentially the immediate induction of labour was associated with a reduction in incidence of severe hypertension without an increase in C-section rate. However, there was a significant increase in the risk of respiratory distress syndrome in the neonate. So therefore, they're kind of unsure whether that can be justified doing immediate management unless there's kind of clear plans, clear indications for delivery. So they do try to prolong the pregnancy if they can, and this is for the fetal benefit. Obviously, the gestation will have a big bearing on whether that is appropriate or not. So if less than 34 weeks, there's a huge increase in maternal mortality of 65 to 71% and perinatal mortality of 80%. And likely, and unfortunately, that will result in likely recommendations of termination within that time. At 24 to 31 weeks, they kind of aim to prolong the pregnancy where possible. And at 34 to 36 weeks, 32 to 36 weeks, they aim to prolong the pregnancy where possible, but they suggest delivering. And then 37 weeks onwards, they just plan to deliver. So these are kind of indications for delivery in women with preeclampsia or gestational hypertension. So moving back to our case study, so we had kind of a deteriorating liver function, deteriorating renal function, and I guess she had some of the persistent epigastric type pain. Okay, and just other considerations, I guess, of management. So preeclampsia is an independent risk factor for VTE. And just to note other things that I'm not going to go into, but, you know, looking at the fluid management and hematological and hepatic manifestations of the disease as well. So what happened to our patient? So she had an emergency cesarean at 11 o'clock that night. After discussion with haematology, she had a general anaesthetic due to the platelets being 59 pre-op. So they gave her a unit of pooled platelets prior to operation. And they were found to have a live male infant with Klein-Licker with a cephalic presentation. She had normal ovaries and tubes, and her estimated blood loss was about 400 mils. And so she was then admitted to ICU for ongoing blood pressure monitoring. And I've just included this, I guess, to, I don't want to go into it, it's very ICU hematological heavy, but I guess just to highlight essentially how complicated these cases can get and how serious they can get. So she actually went to ICU. Her blood pressure was stable and they discharged her back to the birth, to maternity, because it's a nicer environment there. However, her platelets then continued to downtrend, so we saw a drop down to 30. Hematology got involved. They were concerned about another cause of the hemolysis, potentially that she'd developed TTP. And she actually received a right-sided VAS cath, IJ VAS cath. After speaking to the ICU registrar who popped that in, they weren't really that impressed about having to do that with platelets of 30. But she received plasma exchange, further workup with haematology. The Adams T13 came back as negative, and so that was kind of a reassuring result that there was no kind of ongoing clinical signs for TTP, and then she stabilised and was discharged from ICU again. Analgesia was managed with Panadol and oxycodone, keeping in mind that they were kind of concerned about acute kidney injury, so didn't want to give her Nurofen, although I didn't include her EUCs because they were actually pretty stable throughout her admission. And then she was discharged on the 6th of December. So we kind of met her on the 30th of November, and then she delivered that night, and then on the 6th of December, she was back home again. So back to leaving ICU behind and back to kind of general practice. So what do we do postpartum with these women? So in the first 6 weeks, we expect that if they do have pre-existing hypertension, it can become kind of unstable immediately after delivery and may require a bit of a medication adjustment. Any sustained kind of hypertension postpartum to greater than 6 weeks is more common with long duration of antihypertensive treatment. So the earlier that they get this in pregnancy, then it can sustain longer in the pregnancy. And if there's other kind of things such as a higher BMI, or if the preeclampsia did occur earlier in the pregnancy. It normally stabilizes within the first 2 months, and we can switch them to an ACE inhibitor or a sartan, which are compatible with breastfeeding if it's indicated. If the hypertension continues post 6 weeks, then we need to consider other investigations and renal disease, and we need to make sure that the normalization of the urine and the proteinuria resolves. Okay. So she came back to see her regular, much more experienced GP for review at 1.5 weeks postpartum, where she managed her blood pressure. So she'd been discharged on labetalol for blood pressure at 200 milligrams twice daily with a view to wean over the next few weeks. And the follow-up visit with her midwife in the community showed her blood pressure was 110 on 70 with that. And we talked about her mental health with a referral to kind of a post-birth counselling and trauma debriefing. And she had a bit of adjustment disorder in kind of coming to terms with what had happened, and rightly so, I think. And then she required kind of weekly pathology. Examination-wise, at this checkup, she was doing well, healing well, had a bit of bruising around her scar from the low platelets, but abdomen was soft. The male bub, so had birth weight of 2980 grams, and APGARs was 6, 8, and 9 respectively, was being exclusively breastfed, and had a plan in place for immunisations to be given at 6 weeks. So this was her pathology at that kind of 1 week post-discharge. So we see a good resolution of her liver function coming down here, and her platelets are a little bit reactive there, up to 579. So all clinical and laboratory derangements of preeclampsia should recover. There is often a delay of several days to normality, and we can see on the first day or two after delivery that they can worsen before they improve. So after doing weekly checks, the labetalol continued to be weaned down to 50 milligrams, potentially needed some antibiotics for the wound ooze. And then this is her weekly bloods a little bit later, and we can see that there is a real resolution here of her liver enzymes here. Most recently, on the 15th of January, with them kind of being within normal limits, and platelets have settled down as well. So just to touch on kind of postpartum management of her as well. At her 6-week check, her blood pressure had stabilised well. She hadn't actually needed those antibiotics, and she was breastfeeding 3-hourly, and all her bleeding had resolved. Contraception was discussed, and mental health was discussed, and she was linked in with a post-traumatic birth counsellor, and she had good supports with her husband kind of having 3 months off, which is great. Examination was normal, scar was healing well, and then she actually attended the gynae clinic just recently, and where they kind of debriefed further on the birth events. Pathology was reviewed, and that was all normalised, and they kind of discussed the plan for the next pregnancy. So her risk factor for the next pregnancy will be 20% of a recurrence of risk for preeclampsia, and they recommended that she start on aspirin 150 milligrams daily at around the 14 weeks gestation mark to reduce her risk of preeclampsia. They talked about contraception, and she had a Mirena, a planned to return for a Mirena insertion. So almost finished, sorry. So recurrence risk in subsequent pregnancies for preeclampsia. So you kind of determined about the severity of the preeclampsia and potentially of the previous gestational hypertension. And so we see around kind of numbers around the 16 to 47 or 45% if they've had kind of gestational hypertension of having that again, and a kind of a 5%, 2 to 7% of having preeclampsia. I just wanted to finish the talk and essentially talking just really briefly about interconception care. So I guess as general practitioners, we have an opportunity to kind of optimize the next pregnancy for this patient and I guess all women. And that looks at kind of weight, blood pressure, lifestyle factors, biomedical factors and social factors. And so we can see that kind of the prevalence of maternal risk factors by parity, the risk factors, I guess, of smoking and being overweight here and obese. They're all kind of risk factors for poorer outcomes in pregnancy. This is just the preconception care checklist. I won't go into that one. That's available on the RACGP website. I did just want to touch on the outcomes of pregnancy in women with chronic hypertension, because I think this is probably something that we can kind of help to make an improvement on in general practice. So we see that in women with chronic hypertension, we have a 22% risk of all cause kind of leading to preeclampsia. And I guess just highlighting that importance of trying to control that blood pressure early in the pregnancy, if it does come up. I think the blood pressure, the hypertension doesn't necessarily reduce the occurrence of the preeclampsia, but it can help to kind of controlling the blood pressure can actually lead to prolonging the pregnancy, if that makes sense. So I think having severe uncontrolled hypertension often leads to premature delivery or induction. And I think by controlling the hypertension, we can act to kind of help these women reach term a little bit more. So that's all from me today.
That was great, Renee. Thank you so much. And as Ruben said, you did very well to diagnose early and very good outcomes, which is lucky to see you that day. Any questions from the group?
Can I just ask, in these women that are going to have the immediate management, is it always probably going to be a cesarean? Like if you're counselling them, the likelihood that it's going to be a cesarean, is that 100% or 50% or?
Yeah, I thought that was really interesting, Laura. So essentially the studies kind of suggested that induction would they still encourage induction? So I'm not actually sure as to why they went to a cesarean with our patient. I'm not sure whether it was a labile blood pressure or not having access to the notes. I'm not actually sure, but the studies do suggest that they can go on to have induction with vaginal delivery. Yeah.
Okay. All right.
I think it also depends on the time of day it is as well too. Often in the evening, okay, I find when I do my ONG term, I can see Michael in the background smiling as well too. I said that. Okay, when you do go into the evening time, when the bosses themselves are not often on site, the actual the registrar who's on often will actually make a call. Do I want to sit on this person? Will I be actually comfortable enough with my midwifery team to have this person undergo an induction and see what happens? Because if the baby does get stuck, then of course that can then make the actual cesarean much more difficult, and therefore you can kind of committed to birthing through the birth canal, and that can be also quite stressful for the staff as well as for the patient as well too. So I often find from experience that often in the evening time, especially if you're low in staff, then they will often actually shift towards a cesarean more readily. Is that also your experience here, Michael?
Yeah, absolutely. Very, very dependent on circumstances, but I would have thought that induction would be the default first line approach, but then carrying with it an increased risk of C-section.
Yep.
I'm not sure, Michael, maybe you can talk more to this, but in terms of like low platelets and assisted delivery and cesarean, I'm not sure what the risks would be, like one versus the other. I'm not sure if is the surgical the more controlled environment. I'm not sure.
To be fair, I can't say I've seen a lot of HELLP syndrome. I've seen it. I've seen quite a few with preeclampsia, but not a lot with HELLP syndrome. I mean, if you've got the risk of bleeding to within a reasonable level, then a C-section, is doable. Like yes, the platelets are low, but you can top them up. I mean, I'm not sure there's necessarily, like a contraindication or a major issue, and it's not like vaginal birth doesn't carry a heavy risk of bleeding as well. So it's, I think it's probably not much in it, especially if you're in a large hospital where you can provide blood products and ICU and all that sort of stuff.
I was just making the comment that Michael was practicing ONG reds before he saw the light.
Yes.
Yeah, it's interesting. Thanks, Laura. I'm not sure why they went with that. Maybe, as Gordo and Michael have said, it's a timing thing or staffing thing.
I mean, I like the ICU section because we often don't know what happens in ICU, and it's pretty traumatic. They're all wired up and ports coming from everywhere when having a baby is meant to be a beautiful non-invasive occasion. But so it was important to highlight.
Yeah, I think I was lucky that I kind of knew one of the ICU registrars that looked after her, and so they did try to get her back to the maternity unit so she had that nicer experience, but unfortunately she did kind of come back to them with lots of hematological involvement. I'm not going to profess that I understand everything that the hematologist did.
Can I ask a quick question? Renee, that was fantastic. Thank you so much. I really, really enjoyed it. I loved how you progressed through and showed us all the bloods. It was really, really good. Quick question. So if she had just presented with just for a checkup and she'd had some hypertension and that was it, you dipstick fine, whatever, would you then be seeing her weekly to do all these bloods every week? Is that how you would monitor going forward? I mean, probably start labetalol, like you said, but would it just be like a weekly review and then making sure nothing else had progressed?
Yeah, so I think the guidelines kind of do suggest monitoring them really closely, and depending on how severe the hypertension is, in terms of seeing them weekly or bi-weekly and doing like regular protein dips and things like that. Because she was linked into the midwifery program, I guess that kind of threw me that she was coming to me with this kind of presentation, and so I was kind of like, surely it can't be obstetric related if they've kind of sent her to general practice. So I think the guidelines, sorry, to answer your question, Kelly, would be just close monitoring if you are the primary kind of carer for the pregnancy. I did have a slide on that one. I'll try and go back to it and see if I can find it in the meantime.
I guess I'm nervous now because the proteinuria thing doesn't have to be there. So should we be doing bloods every week as well? It just seems, maybe Michael can tell us as well, but.
Saying I think hypertension equals refer to the obstetricians and have them be following closely, and they certainly wouldn't want that woman remaining under the care of the midwives alone at the hospital. They would want to know about her as a high risk patient.
She becomes a high risk patient. So ongoing investigation, of women with hypertension in pregnancy. I'll just share this slide if I can. Sorry, I'm working with 3 screens. I'm not very. Might be. Can you see that table now? No, because
I can't yet. No.
Can you see that table?
Here it comes.
Coming up.
Perfect. Got it.
Yeah. And these are kind of.
There we go. Cool.
Yeah.
So weekly bloods, it says there for the gestational one. But I guess, as Michael said, you want to change her from a low risk to a high risk if she was already not that.
The key term to keep in mind is evolving preeclampsia. So if you see hypertension but you don't see other signs, it doesn't mean it's not preeclampsia.
And I think also that what threw me is this real bilateral kind of reproducible type pain that I wasn't really convinced that it was that right upper quadrant pain. So I just thought that was really interesting and definitely a learning point for me, to err on the side of caution.
So I should also say, if anything I've said implies that you've done anything wrong, I don't mean that at all. because it sounds like a confusing situation where the hospital have said go and see your GP, so that makes it very.
Oh no, absolutely, and that's why I kind of prefaced this talk with, this is what I did. Not sure if it was, you know, the best thing, but yeah, I was definitely open to discussion of what should have happened. So I don't know, maybe if this happened again, I would have just referred straight back to the hospital instead of sending her home.
I think the midwife should not have suggested that a patient with abdominal pain and potential high blood pressure go and see their GP. I think they should have suggested coming into birth unit for a review. I don't think you should have been put in this position in the first place. That would be my main takeaway.
Yeah, especially when the midwives are referring you to you, it implies this is not obstetric related,
Yeah,
this is GP
Yeah.
related. So it gives you that sort of bias. Oh, okay, well, obviously it's nothing serious from that point of view. And yeah, so you've done very well.
Yeah, it's definitely interesting to reflect on this and just see, I guess, differential bias and just how that presentation did actually skew my initial thoughts, because I was thinking, no, it can't be pneumonia. Maybe it's a PD, maybe it's MSK. I didn't do the Chris and go straight to preeclampsia. Maybe next time I will.
Yeah.
Did she request any pain relief before she left that day? Was she like, you have to give me something?
Yeah, so she was in pretty severe pain, and we did I did chat to her about potentially starting some opioids, but she wasn't really keen to do that. So that's why we were kind of like, oh, just see how you go the next 24 hours. Yeah.
I'm wondering here, so too, I know we're talking about the bilateral pain that really threw us. I wonder if it's because of the actual liver swelling and also all the different red cell changes that then she got caught up in the spleen as well too, therefore causing both the splenic and also the actual liver swelling and pain as a result from the swelling of the capsules.
Yeah, definitely a possibility. And I think I don't know, like the reproducible pain, like pain with movement. I'm not sure.
Because I guess any movement-wise, things will be squished inside there, right?
Yeah.
Liver capsule, I guess, could be squished up.
Yeah.
Is your liver capsule squished?
Yes, that's how my brain works, unfortunately. Are you squishing it? Are you stretching it?
Well, thanks again, Renee, and especially for being the first of the year.
Yeah,
so
really well done.
Thank you
That's
for
awesome
volunteering to speak first. Don't know if it was volunteering.
Thanks for volunteering me.
Yeah, so it was a great beginning of the year, and to have you speak. And we love having the registrar speak as well. It's great. And I'll hand you over to Sydney to wrap up. And in 2 weeks' time, we've got Jason Mack, is a ONG on the coast, talking about endometriosis. So that'll be a great topic for us as well. Yeah,
I just thought something else as well too. I recently learned something which I thought I was hoping to share with everyone. Okay, if you noticed already, I'm really sorry. But the thing though is that I had a mind blown moment last week. I was chatting to a friend of mine at work, and I didn't realize that if you actually send through a pathology request and actually ask them to please call me, they will actually call you when the results have come back and actually process in the lab there. They'll actually pick up the phone and give you a buzz, which is something I didn't actually know about. So therefore, sometimes if you actually had, say, a person with kind of atypical chest pain and we're not sure if it's really cardiac or not, and you're waiting for a troponin, then that can be a very easy thing for you to do instead of actually having to check every few moments if the results been downloaded yet to your inbox. This can be a really easy way for them to actually call you back when it's ready, and you don't have to waste any extra energy in between. So yeah.
Great tip. Maybe we should add that to the end of our vertical integrations. Everyone can do a tip of the day. I love it. Thank you.
Thank you.
Thanks, Renee. That was great. Now I'm always the one telling everyone how to do tech, so I might struggle sharing my screen now. I'm quickly just going to share our Lucky Door prizes and see if it works. I say this. Let's see. Let me know if you can see it. Is it full? Is it big? Can you see it?
Yeah, we can see it now.
Okay. So since August last year, we had Kelly and Ruben, Thomas, Callan, Farad, Melissa, and Gordo. So those were all of our lucky prize winners. So if you do ever get an email from the PHN saying like, here's a voucher, click this link, it is not a scam. It's actually your prize. So thank you to everyone for coming today. Let me exit out of this now and stop sharing. I have put the Slido QR code in the chat group as well. So if you take a screenshot on your phone before you exit, that would be amazing. Just fill in our little evaluation so we can keep this program going. I know Dimity, Georgia, and Chris and myself, like we work really hard on getting it up and running. We're always open to volunteers, like Renee. I know Georgia mentioned we have Jason coming up and then followed by Marguerite. So lucky third this year on another case study, which will be exciting, and Andrew Nealon with lower back pain as well. So I hope you can all join us on the 28th for Jason, and we will see you then.
Awesome. Thank you so much.
Thanks, guys. Bye.
Have a great one. And happy Valentine's Day.
Yes.
Yes.
Thanks for listening. Bye.